Hello everyone, welcome. Thank you very much for the Wi-Fi code. It's not working for me, so I don't know if it's just my phone or it just doesn't work. It's weak. Yeah, I know, that's the thing, isn't it? So, my name's Jim. My surname's Blair, like Tony, but thankfully I'm not related. He did a lot of bad things in power. I would seek not to do those things, but that is my surname. And I'm going to pass you over to Andrew, who's going to say who he is. And also we're going to then introduce what we're doing and the first few slides of how you can find your way around the place and everything like that.
Hello, my name's Andrew. I've been doing conferences, and also I'm really happy to be here today because I can get a chance to co-chair again. And also I've done myself one thing because I went to watch wrestling live at the O2, but because I couldn't get carrier tickets the first time, because I know I've got anxiety, but it's the first time I've ever gone into it myself, and I've done it, and I sat in the chair myself, and it all went well for me. Oh wow, when was that? That was May the 15th this year. Oh, well done. Yeah. Yes. Yeah, definitely. Yeah.
Do you want to sing some songs? Do you want to sing a song with us?
Yeah, so the toilets are located by the main entrance opposite the barnum and the Copperton room. In case of a fire, alarm will sound. You need to leave the building and assemble on the car park. And make sure you keep all your personal belongings with you at all times. And there will be some live streaming and some sessions and producing the film of the day. Let us know if you do not want to appear on the film.
And how should they let you know?
By if you don't want to be on the film, let someone know who's doing the filming and tell them I don't want to be filmed, and then because it is like a thing like the data protection law as well, because it's like because that's been changed this year. Also, it's like everything that is like confidential. And also, if you don't want to be filmed, then they have to consent to ask you if you want to be filmed or not. Do you have permission?
Very good.
Yes.
You already know a lot more about consent than an awful lot of health
professionals. Yeah. And also, please keep all your mobile phones on silent.
But do tweet if you get on the... and if you don't get on the internet, you can still use your G4 or whatever it is, G5. I sound like I really know what I'm talking about, but I don't. These are the codes, so I'm going to leave them up for a little minute for you to get logged in. Also, if you could go to part of the campaign that we launched yesterday. I brought the wrong banner, that's typical me, isn't it? But this is the campaign that we launched yesterday, Changing Care, Healthier Futures, and it's at LD Changing Care is the Twitter account. But it'll be formally launched next week on Friday at the Learning Disability National Awards. Have you all got this down, the Twitter code? If you haven't at any point, don't worry, Twitter code, I mean the Wi-Fi code. Okay, so what I want to show you now, if I can just downsize this, is a little clip that I did with Sally Phillips, the comedian, on Monday, but I can't find it now. There you go. And it's not coming up. Oh, there it is. It is coming up. So this, is it playing? Oh God, don't you love technology? So anyway, you can see the fabulous Ollie in the background. That's Sally's son. But this isn't actually playing. So this was going to be a message that she did. Okay, but anyway, that's not working, so we can't have that. Okay, so why are we here today? Well, it's quite simple, really. We know that people with a learning disability tend to have really poor health outcomes, and largely there's a lot we can do about that. And people die 3 times a day, 3 people a day die with a learning disability avoidably in this allegedly developed country. And I think we've got to say allegedly, because if it is a developed country, then you have to question what society it is that permits this to happen. And there is permitting it to happen, because without stopping it, we are almost accepting that it's the way it is and it's not the way it should be. So that's 1,200 a year that shuffle off this earth avoidably. There's a lot we can do, and there's a lot that is being done, and today it's about celebrating really good practice and making sure that we share that and evolve the care together. Because although people die within hospital settings, and that's not care and treatment places, by the way, they are not hospitals. So let's get that confusion out of the way. NHS England calling them hospitals was not a clever move. They're assessment treatment services that may or may not do something to help somebody. But the actual acute hospitals where people are dying at that rate, it's what's happening before the hospital when people come in from the community. And that's something that everybody can do something about. So it's all about seeing the person, see beyond the disability, and behind every behaviour change, if you just do one thing, consider a physical or mental health reason behind that and act. Don't delay, it costs lives. So keep pushing. I know that there's the fight within everybody in the room to do that. But we are moving forward on many things. And over to Andrew for a few words, and then we're going to go into the programme as set out.
And also, before we go into the programme, I'd like to say that with people with learning disabilities, we're all different than anybody else. And we want to be like normal people. And also, the fact is, no learning disability is no different than anybody else.
So now we're going to go down to, I love technology, don't you? So we're going to go into the next piece, which is Tom and Rona and George. I know Tom because he used to work for South Downs. Did he? Yeah. I didn't know that. Yeah. He's a very nice guy, though. Tom used to work for PBS for South Downs. So here you are, and this is Claire and not Rona. So I was just getting confused. I like it. You love it when you get thrown, don't you? There you go. Want me to play around this?
That'd be brilliant. Thank you. Can you hear? Oh, yes. So I'm Tom Evans. I work for Build, and Build are facilitating the community of practice and helping with the event today. And this is Claire Lee, who is our new network coordinator. So Claire's going to be saying hello to you throughout the day, introducing herself, and over the next 6 months, getting to know more about you and what you want from the community of practice. We're just going to really briefly look at what at the event last year, we held a consultation, and these are some of the things you told us about. So, okay, that's fine. So last year you said you wanted to have local meetings. So we've run local meetings throughout the region. So in West Sussex, in Brighton, in East Sussex, in Medway, in Canterbury, and in Guildford. We're going to continue to do those, probably changing the format slightly and putting in a CPD element based on the feedback of people who came to the meetings. They wanted more of that from the meetings, but there's still an appetite for those meetings, so that will continue. We also asked for champions at the event last year. Various people put their name forward, and there have been champions doing excellent work over the last year. Some of them are here today. And again, we're going to continue that work, and we're probably going to be asking for more champions in specific areas. We last year wanted a champion who was an LD liaison nurse, and we have now an excellent champion LD liaison nurse today, Eloise, who's running a workshop, so say hello to her today. We also need to find a GP champion. We're getting closer to finding a GP who's prepared to be a champion, but if you're aware of a GP who feels strongly about people with learning disability accessing good healthcare, then do let Claire or I know. We really need to have a GP to champion some of this work. We also talked last year about an online options. There's been some delay in that, but we're really pleased today that we're able to launch the fanfare, a Facebook group. It's going to be called the Kent, Surrey and Sussex Learning Disability Community of Practice. It's going to be a new closed Facebook group. The idea being that community members can communicate with each other online. This is a great opportunity to communicate face to face. We're launching it today. My colleague Lisa Richardson, who's out there, who helped you get badges when you arrived, she'll be signing people up throughout the day. She has a stall right down the far end near the cafe, and she'll be signing you up, helping you understand how to use it and how to get online with that. The idea is, part of Communities of Practice is all about sharing the excellent work that you're doing with other people. There's a nice phrase I heard George use recently, and it's about preventing wheel factories. So we don't continually reinvent the wheel. It's about sharing the good things we're doing. And one way of doing that is through online communities, and that's what the Facebook is for. We also need to consider how to make this group, this community, sustainable longer term into the future. We've considered various options over the last year. These are some of them, and we just want your opinion. So what we want you to do is, as you go through the day, think about these things. You don't need to give a response now, but we want you to just write your thoughts on a post-it note. There'll be some bits of paper at the back of the room there throughout the day. We just want your views on these points up here. So first option would be membership fees. Probably quite unpopular, but it's there as an option. Membership fees could be for individual community members, or it could be for an organisation with a certain number of people within that organisation, but I think probably fairly unpopular. So another option is sponsorship. So that's about getting organisations, large organisations, to sponsor the community of practice. They see the value in it, they want it to work, they want it to carry on. So that's an option we're exploring. Now, these are other ways of making the community more sustainable up here. So extending the geographical borders, if you like. So currently we're bounded Kent, Surrey, Sussex, Brighton and Hove and Medway. Possibly extending that geographical reach would make it more sustainable. Including widening the remit, if you like. So we've had interest from education professionals who are equally committed to people with learning disabilities having good access to healthcare. Particularly bringing them into the community would be one way to make the community larger, therefore more sustainable. Might lead to more joined up working as well. Elsewhere, communities of practice we've been involved in, the idea of a steering group, so a group of people who have influence, representing the various sectors, representing the various professions, leading the development of the group, therefore making it more sustainable. So these are options. We just want you to leave your thoughts and comments on all of those. So I guess the key things are, the first question is membership fees or sponsorship. That's the first question. And the second question is the points on these slides. What do you think about these? Do you have strong views? What do you think about these? What we'll do is we'll leave this slide up during the breaks. So if you come back in, you can remind yourself the questions we're asking you today. Thank you. George Rona, would you like to come and join us? Do you want to say something about registration?
Just while we're getting the IT set up, if anyone hasn't registered and popped their name on the list at the front, if you could do so during the day, or grab myself and I'll pop your name down so that we can capture everyone that's attended. Thank you.
And just before I pass on, I'd just like to say, give a round of applause to Tom, because with Tom, he's helped me from PBS and he's done a lot for me. So give an applause, please.
Well, I've got a presentation, but it's not coming up, which is a shame because I was going to talk to it. But never mind, I'll say what I can remember and ask me questions. So my name's Rona Westrip, and I work at Health Education England, Kent, Surrey and Sussex. We're actually based in Crawley Hospital across the way. And I'm Programme Manager for the Intellectual Disability Programme, which is also across London and the South. We're very proud of the programme. It's the only one within Health Education England. So really proud of that. George is the clinical advisor for that full time. So I'll tell you bit about Health Education England, because a lot of you might not know it and some of you do. So we started off in, I think, 2012, 2013, where basically we were formed from the strategic health authorities and the deaneries, and we took over all the functions of those. There we go. And we've got just one really simple aim: to support the delivery of excellent healthcare and health improvement to the patients and public of England. We're very lucky. We get a mandate from the government every year that tells us what to do. And that for us is very important because it gives us permission as a programme and as a local office to actually make a real difference to the people working in health and social care, and to the people that we're here to help, to the public. So that's us. We're a non-departmental public body, and that's a little bit of information about the mandate. And that's us. Keep going, Jim. Yeah, no, it's all right, keep going. Right, so just a little bit about the Intellectual Disability Programme. We've got a really simple aim to secure a sustainable workforce supply for the people that work with people with intellectual disabilities and or autism. So it's a really, really simple aim. The aim is simple, but it's also quite wide. We don't just work with learning disability nurses. We don't just work with doctors. We don't just work with the registered healthcare workforce, because we know that actually all these people make up a tiny percentage of those that work and look after people. So as part of our programme, what we've been doing over the last 3 years is gathering evidence about the workforce and about numbers, but also talking to people who actually have intellectual disabilities and talking to their families and carers about what they want as well, because that's really important. We don't want to be a programme that's seen to do things to people. We want to work with everyone. So that's been our aim of the programme. We started off in 2013, where George was asked to provide some evidence that there weren't enough learning disability nurses across Kent, Surrey and Sussex. He produced a report that was very much learning disability nurse focused. At the same time as he produced that, Mr. Cameron told us that the bursaries were actually going to be removed. So we immediately knew that as an organisation, we were going to lose a lot of the influence that we had regarding learning disability nurses and how to get more of them and how to commission more of them. That was all going to go. So that was when we started looking at the wider workforce in detail. As part of that work, George introduced me to what was then the Kent and Medway learning disability community of practice, and it was a small group of individuals who were really dedicated to eradicating health inequalities for people. And they were doing fabulous, fabulous work, but it wasn't sustainable. They were all doing it in addition to their day jobs. They were all busy, busy people. So as Health Education England and as part of the Intellectual Disability Project, we started to look at ways we might help to open it up to a wider workforce and open it up to more people, and to get the message across, because we thought that this was a really good arena for people to start to share good practice and to start to really discuss things and find each other, find places to go to ask questions and things. So the community of practice extended and it became Kent, Surrey and Sussex Community of Practice. We were then able to secure some funding via the programme at Health Education England, and we asked Build to look at helping sustain the community of practice. Because what we want to do, and what we are doing as an organisation, is hopefully putting this community of practice into a place where it is sustainable without us, because we haven't got any more funding to support it, which is what Tom's been talking about with Build. So we've moved through that, and you as people from the community will be the people taking it forward. So please do take on what Tom's been saying, and get other people involved as well. So that, I think, that's a very quick snapshot. I just want to say, if everyone can become a stakeholder for our programme. It's absolutely free of charge. Please do. We've got, if you look at the WordPress site, you can sign up to that, those of you that haven't. It's a really nice website where we just inform you of the work that we're doing. We produce a blog on a monthly basis. We tell you about other stuff that's going on in the local community. And anyone can join it free of charge, and you'll get an email once a week with headlines that you can choose to click onto or not. And it's also part of the process. Once you're a stakeholder, then you will actually become involved in some of the conversations that we're having. And there are, at the moment, we've got 40 pilot projects, which we've helped stakeholders with by supporting them surrounding education and training. So there's also offers of support and things that will go out. And I think that's it. Thank you very much. Thank you.
And also, I'd like to say that she's done very well, because what it is, it's the action you want to put forward. You want to make sure, because when you get building that, anything can happen. It's not impossible. It's things that can happen, and disabilities as well. So she's done very well.
Absolutely true. And if you think if things aren't possible, then you know Andrew supports Leicester. That they did the impossible, so you can shift stuff. Oh God, it's going to be a long day, isn't it? Foxes and hammers. Oh dear. But yeah, look forward to today. The workshops are going to be great. It's about engaging, having fun, and moving things forward. The fact about society is we are society. We can keep it the way it is, or we can try to change it. Those in Westminster don't really have the power. They think they have the power, they don't. The people who have the power are us. And if you look at the recent events where the person in charge of this country shifted her thoughts quite quickly in relation to those with epilepsy and that particular cannabis oil situation, you can see how things can shift. It does take a lot of time, but there is movements to move that forward. And that's where we need to be a movement, and rather than just sort of singular campaigns, there needs to be a movement for change to evolve the future the way we want it, not the way it may currently be. So that's the idea behind today. Wouldn't you agree, Andrew? Yeah. Don't you love it when you put someone on the spot and they have to agree? So we're now into the workshops, and I'm going to read them out again. So if you can't remember which one you're going to, don't worry. So in one, we've got development and implementation of profound and multiple learning disability core and essential service standards with Michael. And I see him here. Nice to see you again, Michael. It is like bullseye. In two, we have ways of communicating. You see, you've started me now. I'm going to finish. Ways of communicating and reassuring people with learning disabilities to feel able to speak up, including about their health. And in three, the overcoming the challenges in administering emergency epilepsy medication and assessing the administration with Jenny. And in four, the evaluation of mental health promotion groups with Peter Woodward and those with learning disabilities who have steered that and moved that forward, which is fabulous. And in five, we've got the Avenues group, It Takes Two. So I'd be fascinated to go to that one myself, because I'm sure that's about dancing and everything. But that's about how we communicate and ensure that people have equality of access throughout services. And that's with Martin and the Avenues group. And in six, which is here, it's with the wonderful Andrew and myself looking at challenging health inequalities. And in seven, empowering and recovering college peer trainers with intellectual disabilities to take up strategic positions in promoting mental and physical health and well-being. So choose your groups, get involved, get engaged, and remember, we are the change. There is nobody else that's going to do it. Thank you.
so many people are joining it. It's probably so busy.
Wow. Well, everyone come to the front because you're far too far away up there, and we're very shy. Very scared. Well, that's just me. I don't know about Andrew.
Yeah, you want to get everybody forward.
Come on the front with all the boys at the back.
Yeah, because if we try and get the boy trampoline, it's not go that far.
Do we have to sit down? We can't sit around.
Yeah. And I know him. Yeah, because he did a lot of stay up late.
Yeah, he likes to stay up late.
Yeah.
He's got a real problem like this. Chelsea's like that.
Yeah.
But Peter, when he was alive, Peter Patterson down here, Pete, I converted him to a West Ham Wales guy. He used to be a Chelsea fan. That's really unethical of me. I should be
Oh,
struck off
God,
the career.
no. That's worse.
Actually, his funeral was actually we had a fabulous time at his funeral. Lloyd cracked some jokes and everything. As funerals go, very entertaining.
Well, if we do win Sunday, then we qualify if we win Sunday. But it only depends if when we go against.
Okay, so we'll start. So we've all said hello to each other already. So I'm Jim, and this is Andrew. And I had no idea I was going to meet Andrew today, or that he was going to do this session with me until probably about 5 to 10, which was lovely. So that's why Andrew's name doesn't appear up there. This is the first time we've met, isn't it?
Yeah, it is.
I have seen you on film before, but we've never actually met. So it's working, is it now? Okay. It's working now. Lovely. So I'm going to start, and Andrew's going to chip in all the way through and talk about his own experiences. But do chip in yourselves at any point you like, whether you like what we're saying or not. You can disagree. You can challenge us. That's lovely. That's what we need to do. So everybody's life has worth. Sadly, in this country that's about to depart Europe, which is not a good move for people with disability, for a start, we don't really view as everybody's life as actually having worth. That's the reality and the sad fact in 2018. Because if we did, 3 people wouldn't die each day. But these people up here are all people that I know, and their lives, like many others, and everybody's life, has worth. So at the top, you've got Yvonne Newbold, smiling away in a purple top with her wonderful son, Toby. Toby has severe learning disabilities and behaviour that some people find very difficult, including himself at times. And Yvonne has written a Special Parent Handbook. She's got a wonderful campaign going around violent and challenging behaviour from children towards their parents. And very sadly, a lot of health professionals who are often a bit ignorant consider behaviour that challenges others and children attacking their parents as being a parental problem. Somehow parents have done this to their child, therefore that's how they've learnt this and that's how they're behaving. It's a really strange conclusion to come to, but it's one that some people do hold. And Yvonne's busting that with the fabulous Viv and the Challenging Behaviour Foundation. So Toby has a very happy, fulfilling life now. He's a real character. And in the middle, you'll see with the pink scarf around her neck, that's Kate. She works at Build. And if you can see clearly, you might not be able to see her very well there, but Kate was in the first program of Undateables. She, as I say, works at Build, and her biggest problem in life is she supports Everton. I know, it's terrible, isn't it? And then you've got here, over the other side, in the lovely red tie and the purple shirt, that's Scott Watkin. Scott, I consider to have been the National Director for Learning Disabilities, not Rob Gregg, because I think Scott's did much, much more for people with learning disabilities than the other person I've just mentioned. Although very good, the point is it's people with lived experience that make the bigger shifts than those without. And he works for Seeability now. The picture of the wonderful smiling Daisy, this is Daisy Nimmo. Daisy sadly died last year, unavoidably, and she had a very fulfilling life. And her mum, Steph Nimmo, wrote a book called Was This in the Plan? About her daughter's short life and how it changed her. And she's also produced a number of publications with me, as has Yvonne and a number of the other parents that are up here as well, and people with learning disabilities. So over there you see a house that's quite important in this country, the House of Parliament. And you will see in front of it more important people than those that are in the house. You've got Josie, this is Josie down here. You've got Chiara Lawrence, who's just to her side. Josie and Chiara work for MenCap, and Chiara was on a 30-foot poster screen at the U2 concert. Her cousin is the Edge, the guitarist of that band. I feel like there's a tour guide here now. And over here, you have Ishmael Kadji with his hand out. Ishmael is a man with a learning disability who is the parliamentary officer at MenCap, and Ishmael has 3 children. And he has written with me about what it's like being a parent, going to hospital, and people saying lots of stuff that you don't understand. And he's the father who has a learning disability. So that's some of the challenges he faces, as well as his own health interactions. Okay, so this is Christmas. Bit of a giveaway. But what you'll find with Josie is she's kind of like that most of the time. Not necessarily so sparkly, but she's got a wonderful sense of humour, and she's really a very colourful, flamboyant character. Here you've got Lloyd Page, who loves to crack jokes. He just tends to brew them most of the time. And if he was here, he'd certainly be cracking those jokes now. He works at MenCap, has been doing so for 24 years, and has a room named after him there in recognition of what he's been up to. We've done lots of work over the last 20 years together. This is Hayley Gloshkanskaya. Hayley is the mother of Natty on the side, and the creator of Downside Up group, and has published a lot, blogs a lot, and has done a massive amount for people with Down syndrome and for people with learning disabilities in general. And her daughter Maya, who's the sister of Natty, wrote a book called Loving Natty about what it's like to be a sister of someone with a learning disability. And this is the wonderful Peter Cranham. Peter died, as I said, in 2014, unavoidably. And I had the honour of having been his nurse when he came into St George's, the hospital I worked in South London. And then when I left that hospital, I became his health advocate and helped him and his sister to ensure that he had a good end to his life as he could. And we had a fabulous funeral for him, which was very, very entertaining, which I can tell you all about if you want to hear it at another point. And over here we have Natty, and I don't really know what Hayley's doing. I think she's probably worrying about her daughter's shoes or something. And this little lad, who I don't know, is fabulously paying no attention to anybody, but just looking at his lovely sock, which is claret and blue. So I like to think he obviously was a West Ham fan as well, but he may not be. Okay, so I'm going to sit down now because I think it's probably easier to do this slideshow from that. So we've talked about these 3 people that die every day. And why is that happening? Why is it still okay to happen? We have report after report after report, campaign after campaign after campaign. But does much really shift? Ask yourself this: in the 11 years since death by indifference, how has this society really improved the health of people with a learning disability? And at the same time, you've got 50% of universities that provide learning disability nurse training, and there are other fabulous nurses and doctors and carers and supporters and therapists around as well, closing their programs at the very time we know the impact that what they make. And when you look at it, a hospital that I work in, we've got 8 learning disability nurses. When I went there 5 years ago, there was 0. So the argument to infiltrate and embed learning disability nurses on all areas is not a hard one to win. It's just how you sell it. Lives matter, every contact counts, and making sure that we do make it better.
Yeah, and I think where it's about people dying a lot, it's basically what's happening is we're not getting a lot of NHS care, And I think what's going on is like with the government, they're not paying a lot of money for NHS, and I think they should, because I think people like us, we need to be treated, and we need to be having doctors and that to help us.
Oh, that's quite right. Well done, Andrew. It's true, isn't it? So, Andrew, do you want to talk about what it's like? Oh dear. Oh, there we are. We've jumped back a bit. Here we go. So going into hospital, does that how it feels like for you sometimes? Do you want to explain what that might be like?
Well, basically with the health service, I find it a bit scary because I remember the first time I went to the hospital, like when I became diabetic since I was 17, I'm now 33. And when that happened, I didn't realise I had it, and I felt really scared. And I did not know how to deal with my diabetes. But what happened then, I did very well with injecting insulin type 1 with my diabetes. I was out the next day. But the thing about it is with the reason why I inject, it's because my pancreas is broken, and because the pancreas produces the insulin, and because I'm not getting the pancreas broken, I can't get that insulin. So that's why I'm having to inject it in. And also, you can get, sometimes when people are like overweight or things like that, you get something called type 2 diabetes, and that is basically when you have tablets and that. And to be honest with you, it was very scary, but being now, I find it very easy to use, but I'm still getting support from my carer Phil as well and other people, and I'm still getting happy. And the thing is, I'm finding it hard, but still, I've got support there when I need it.
Great, thank you for sharing that. So when you went into hospital, did the doctors and nurses treat you well or not well? So what was a good experience and what was a not so good one?
Well, when I first went into the hospital when that happened, I felt scary about the doctors, what we're going to do or how it was going to happen to me, whether I'm going to get better or not. But the bad experience I have had in hospital is like when it's the waiting time. It's a waiting time there, and you're thinking, God, it's like gone about 2 hours, and doctors and nurses still haven't come and seen me in that. But at least the good experiences is when I get the nurses and the doctors eventually helping me get better, and that's the main thing.
Great. So important. Small things make a big difference, don't they, to people's lives? So often people spew out words. It's just linguistic gymnastics for the arrogant health professional. It makes no sense to the person in front of them. And often people forget about who's in front of them. So whether you've got learning disability or not, the fact that you're unwell, you're anxious, you're frightened, you're scared coming to hospital means you're not going to be functioning at your usual level anyway. So if you're just given loads of splatter words, it doesn't make any sense to you. So when you think about it, does anybody feel really patronised when you're on a plane and you get the safety cards and it's all just in pictures? No, you don't. You go, excuse me, can I have one that's 5 pages long, please, with lots of small text? Because I don't like pictures, that's really patronising. You don't, and when you're driving down the motorway, you don't go, God, not again, he's blooming pictures. I want an essay down there. And then what would happen then? You go smack, 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 everybody gets killed. It doesn't matter, I've read it anyway. Pictures make much more sense than words. And interpreting them makes it a lot easier. So I think it isn't a big ask. We produce things in Brexitese, German, French, Welsh, Romanati, Romanian, Bulgarian, whatever languages you fancy. That's a waste of money. Because the people that want to access that in those languages, that can read those languages and are in this country, are likely to be able to understand the language that's in the country to some extent. And whether they do or they don't, what they will understand is pictures. Therefore, you don't need to translate pictures. You can use images to get the message across much easier.
And also with that, the main thing is having it easy to read as well with pictures. Because if you have like just writing and too many big words, people are not going to understand that. Because like disabilities, like with autism, right? I've got autism myself, and what that is basically your brain's cross-wired. So basically, I could see things differently to what a normal person would see it. But to be honest with you, it's like the best thing to do is if you're doing anything like health action plan, or if you have that, just make sure you've got like pictures on less words in there so it can help understand more.
Great, thank you very much. I think the slideshow's not working again now, so we're just going to have to talk it through. So everybody can make the change that they want to see. Small actions make a big difference. You don't have to do a huge amount of things to make things right. And some of the things that we can do around the inequalities that people face, there's a lot of fundamental problems of why people have poor health outcomes. And it's around sort of the global political forces as well. It's about inequity of people with income, through to what this impacts on their learning, their ability to engage in their society, and almost the exclusion that they have from that. And from those episodes. I don't know what's happened to the slideshow, but I'll just talk it through anyway. So why is it happening? Well, people with a learning disability are more likely than others to be exposed to poor health and outcomes from infancy onwards. So that's right from the early start. And it's around the sort of the link with disability and poverty, low social status, low control, and often, very sadly, victimization and abuse does take place for these individuals. And what are the key health issues that people face most? Well, there's much higher episodes of gastro problems and cancers, and people often don't pick up on the non-verbal cues. It's really interesting, and I find it quite fascinating to see colleagues who are quite able to tune into a child that may be under 3 and have no verbal language, but they really struggle when there's somebody who's 45 and has no language. And you're thinking, really? Why are you doing that? How do you do it with the other person? So supporting people to change, to say, well, so what did you do for the 3-year-old, the 1 to 3 that doesn't speak? Oh, well, I looked at the whole person. I read the whole person. Well, why is that different now? So it's about seeing the whole person. If I just start doing this, do you think that's just because I fancy itching my shirt? It might well be that I've actually got a esophageal reflux problem, and I might not be able to articulate why. So I might be gouging out my chest. Not because I fancy self-harming, but nobody's born self-harming. It is not part of the disability. One of the biggest killers for people with a learning disability is diagnostic overshadowing. And that is when you put things down to the disability rather than exploring why. So I'm a white guy who's 51. Thank you very much. You're all stunned at how old I am. I didn't get any response for that, did I, Andrew? They obviously think I look much older. But if I get up and smack my head against that wall, is that what you think guys that have just come down from London who wear glasses are 51 and happen to be white and support West Ham? Is that just what they get up and do? No, you don't. But throwing a learning disability into that mix, oh, it must be the learning disability that's done that. Funny, isn't it? That one thing, or 2 words, has triggered some change in people's perception of the reasons behind that. The one single thing, can save lives. And that is, behind every behaviour change, consider a mental or physical health reason and act. Assess what's going on for the person, consider mental or physical health reasons and take action. Don't delay, it costs lives. And don't accept people saying to you, it's not important, we don't do those sort of tests for those sort of people. Well, who are these sorts of people? Who is the norm? I would love to consider myself as a glamorous deviant. I certainly wouldn't like to be considered to be whatever normal is. And so I think it's really important to check behind that. Think of why is it that people can die of constipation? Why? Why does somebody die from bowel cancer who had rung up the hospital on 3 separate occasions and had told the administrator that they've got diarrhea? But the preparation they were given the night before by that clinic gave them the diarrhea. And yet the admin staff, no fault of his or her own, said, oh, you can't come into the hospital. Well, actually, that's not true, because those clinics are on the outer areas of hospitals for very good reasons. So they don't go to the general part of the hospital where they might give people other things. And that preparation, that person had 3 points when they were missed. Why is it that we have people in their 20s dying if they've got a gallbladder problem and they've had mental health problems as well as a learning disability? They're in a general hospital, they go into there, mental health problem deteriorates, they become much sicker mentally, and then they're moved to a mental health unit on the same geographical site. And yet everybody then ignores the underlying gallbladder problem until what happens? it gets bigger and bigger, and it bursts, and the toxins kill her. Real case. Real case. I investigated that for the Ombudsman and found that there were 5 episodes where there was clear evidence of diagnostic overshadowing. 5. At each point, that person's life could have been saved. At the point of death, no, nothing could have been done. But it's what happens before. That is why the movement that was launched yesterday is about changing care, healthier futures. And it is about making sure that it isn't just focusing on what's happening in the hospital, because that's not all the picture. All you see isn't all that there is. So don't just look in one area, look across. And if one message that comes away from today is behind every behaviour change, consider a mental or physical health reason. The problem is, the other thing that's been killers of people with disability is the social model of disability. Yeah. Bit of a radical thought, that. The medical model was wrong, the social model is wrong. Because the social model started to ignore the health. You ignore health, you kill people. That's it. That's the equation. Don't muck about, that's the reality. The thing we need in the middle is a health and well-being model. It's the whole person. Health and social care of part of a person are just heads and tails of the same coin. It's a bit like saying, well, can I do all right with my foot? The argument about learning disability nurses or not to have them, if you have epilepsy, would you expect to see a clinical nurse specialist for epilepsy? If, like Andrew, you got diabetes, should he bother to go and see an expert in diabetes? Well, no, because he's got diabetes, doesn't really matter. So why are we, in 2018, even debating the idea of learning disability nurses? If you've got a learning disability, you should see a learning disability nurse, in addition to other people. Why? Because they can tune into your frequency more quickly and aid and guide and support colleagues to get it right for you, with you, and for you. So it's all about that. So I'm going to pass you over to Andrew for a second. Yeah.
And also one or other thing is that with learning disabilities, we're always put in a different group. So say like we want to get a job, or if we want to do like health, because like health comes first before anything. But it's like you get like these people and they say, oh yeah, because he's got learning disabilities, we'll put him over here, we'll put him over here, not in any other category. And it's not fair because not only that, we need these nurses, we need people to help us, not just shove us in the corner, because it's not right.
Quite right, quite right. And the other thing is, it's much more common. And I do think if you are, wherever you work, whatever you're doing, go to the British Heart Foundation, look up the, I was telling Andrew about this when he told me he's got diabetes, look up Living with a Healthy Heart. It's a really good package about how you can get health information, health promotion, and materials that will create solutions for you for and with people with a learning disability. Don't worry about the narrator, because that's me. The key people are the 6 people telling their stories about trying to give up smoking, and they do video diaries of it, and it's really funny. James is a real character. There's quite a few beeps that go in there, because he swore quite a lot as the filming was going on, which is great, but actually it gives a real reality, because it's people giving their experiences to others. And I was saying to Andrew, it's a really good resource for him to look at, because you can see somebody else that's like you, or similar to you, giving you their experience of why it's quite hard to live with diabetes, it's quite hard to do things, but actually you can do lots of stuff, and they show how they can do it through their actions and what they're doing. So, when you think about it, why have we got the case of people dying? Why is it that by virtue of the fact I'm a man without a learning disability, I'm going to live 13 years longer on average than those with the learning disabilities? And women, congratulations. You're going to live 20 years longer than women with a learning disability, and largely that is down not to the fact that they've got a learning disability, other than the fact that people don't pick up on or tune into their needs. The do not attend rates in hospitals are vastly higher for people with a learning disability than those without. Are people really exploring the reasons behind that? One argument to get more learning disability nurses in your areas and where you want to work is to say, actually, these nurses will stop those things from happening. You will reduce your cost of not having these appointments, not having these clinics, and the cost to people's lives, most importantly. You'll pick them up earlier. So it really is a very, very important thing to do, and one that we can all push for. The other area and reason why people die much earlier is around screening. Screening uptake for people with learning disabilities is appalling. It's really, really bad. both men's screening and women's screening. If you think about breast care, you think about cervical smears, you think about all of this sort of stuff, and testicular examinations and prostate examinations, they don't happen very much for people with a learning disability. Would that be acceptable if you were Welsh, or if you were a Brexiteer, or if you were from Putney, or Birmingham, or Manchester, or from the Caribbean? Would that be acceptable? No, it wouldn't. So well done, you've worked out I'm a white guy who's 51. Now imagine the person to my right is an Afro-Caribbean guy who's 51, probably a lot more handsome than me. But is it racist to say we're going to screen him for sickle cell anemia? No, evidence-based, because he's much more likely to have sickle cell anemia than I am. If you get someone, Mahendra, same age as me, East Asian background, clearly. Diabetes and cardiac problems are much more prevalent in people from East Asian backgrounds. So we already discriminate based on health evidence to focus on the needs of particular groups. Are we doing that for people with a learning disability? Are we really pushing for people's lives? Are we really driving and penalising services that don't deliver on annual health checks, that don't deliver on the fact that poor outcomes are happening? Are we really pushing people to do things? Are we really ensuring that people's capacity is effectively assessed and it isn't just a blind sort of thing, oh, well, they've got a learning disability, they don't really understand? Well, have you bothered to check it out? Have you bothered to find out? You saw Peter at first. When I first met Peter, he had been in the hospital, he came to the hospital I was working in the night before. He had very poor lungs, chronic obstructive airways disease, and he was absolutely in a terrible state. He'd been crying all night, he was very scared, very frightened. My colleagues were saying to me, oh, you see, he hasn't got capacity, he doesn't know what's going on, doesn't want to do it. And I said, okay, right, I'll go and have a chat with him. So I said to Peter, I said, can you breathe? We had a chat about other things, and he did. And I said, okay, so the air that's going in to here, they're your lungs, they're like balloons. And he went, oh, okay. And I said, put your hand. So he put his hand on there. So, right, that's it. Mine are okay at the moment. Yours, they're not so good. Okay? So what they're talking about doing is putting a tube to get some of the fluid away. And then I showed him what the tube would be like. What do you think he did? I said, do you think it would be a good idea to have it or not? Yes. That was it. It didn't take long. It literally took me about that amount of time, maybe 10 minutes max. And that was it. It's about describing things. And it's about finding out where, you know, if you ask people where their heart is, if they've got a learning disability, where do you think they'll say? Often. Or how big is their heart? Well, Ollie Phillips on Monday when I was with him, I tell you how big he thought his heart was. He said to me, it's this big. And I said, that's fabulous, Ollie. I said, where does that fit in your body? And he looked at me because actually that's bigger than he is. And so I said, okay, so do this. So he did that. And I said, okay, put it towards your chest. So he did that, put it there. I said, that's how big your heart is. And he went, And then we started talking about petrol and the blood being the petrol of the body and the heart being like an engine. He understood it. He got it. Then we talked about it again. Talk about, you know, people talk about where their heart is. So I've had people say it's here, 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 don't know, here, here, or wherever. So when you think about a blood pressure, why is it that somebody's going to get very distressed and start punching somebody when they talk to mum and dad or the carers and then suddenly want to come to Andrew and grab his arm and take blood pressure? Well, it's not really surprising, is it? He hasn't got a clue what's going on. Would you do that for anybody else? So why are you doing it with somebody who clearly that's going to be really traumatic for? You know, you get people with Down syndrome and people appearing from the side. That's not a very good idea. Why? Because most people with Down syndrome have very poor peripheral vision. So they'll hit out. Oh, yeah, they've got challenging behaviour. Well, actually, you just created that behaviour because you didn't need to do that. You could have avoided that. Come to the front, come gradually and speak to them calmly, touch them, let them know you're there. It's not hard. None of this is actually that hard to do. And Viv and many others in the Challenging Behaviour Foundation and other work have really challenged that perception, and it's great because the behaviour that challenges is normally created by those that don't have the learning disability rather than the person that does.
Yeah, but the The thing is though, that like you're saying, it's not hard. It is hard because people learn disabilities can find it different in different ways. Because with people with autism as well, they can think different to what you're thinking, and also it can be hard for them.
Yeah, you're right. It can. It's very hard for people, and I don't think. I think you're right. I totally agree that you can't have one rule for all. One size doesn't fit all. It's a bit like the autism idea that you see one person with autism, you've met one person with autism. I think that's probably true for everybody. But it's really, one of the things I've come to think about a lot is it's about, you know, the old radios that used to go like that. That's what it's like when you first meet somebody. Now, I met Andrew for the first time this morning, about 10 to 10. I'd never met him before in my life. First question I asked you, what was the first question after you said who you were?
The first question you said, what football team do I support?
What football team do you support? Now, why is that important? Certainly, if you think about, if you're coming in as a patient and you're seeing me in clinic, why is that important? Leicester have won the title. West Ham have never won the title. So who's on top? But if you see somebody wearing a football shirt, if they come into the clinic and I'm in there, I'll always sort of say to them, oh, seem like such a nice person for a Chelsea fan. What does that do? If they can understand and can hear what you're saying, they like to get angry. Fabulous, I've got your attention. Now we're going to have a dialogue. Because they're up, aren't they? I've wound them up. Brilliant. Then I say, do you know what? Could be worse. You could be like me, support West Ham. So in the hospitals I've worked in, I've had people shouting out, going, oh, there's that man, he supports West Ham. And that's it. But it's great. If that's what they remember me as the West Ham nurse, that's fabulous. Because it means they're on top. So the use of humour is so important. And the thing about saying something like, you've got a fabulous pink dress, pink top on. That's lovely. You know, say something about the colour, what people are choosing. It relaxes people. So it's a very simple thing to do. So if you think about who comes into hospital every year, so in the NHS, 45% of all money spent is in hospital care. That's a lot. And yet only 14% of the population use hospitals each year. Yet 26% of people with a learning disability access hospitals each year. Yeah, huge. And if you think where we are now, we're 9 years on from one of the best people I've had the privilege of meeting when she was the Parliamentary Health Service Ombudsman, Anne Abrahams, who challenged a lot. I mean, she didn't do everything perfect, but she challenged a lot in her report, A Life Like No Other. And she said, the quality of care in the NHS and social services for people with learning disabilities is at best patchy, and at worst, an indictment to society. Whoa. That's 9 years. 9 years. So that's 9 times 1,200 people died. This room would be empty of people. So you three that died tonight, you three tomorrow, you three on Saturday, you're on Sunday, so you don't watch the football, unlucky. Monday, Tuesday, Wednesday. By Thursday next week, we're all gone. That's okay, isn't it? It's not. But what do we do to shift the thought for government and others to shift that? We do that by what we do to show the worth of people and to push for it in a very active, positive, solution focus. There's got to be solutions. There's no point otherwise. There's got to be solutions. Do you want to say something, Andrew?
Yeah, and also it's like with learning disabilities, we should be included, not excluded. Because we should have what we want, and it's like when 2012 came and what was going on when the cuts were happening. I was actually Chichester County Council, and they were going on. There's a lot of protests going on about it, and I had the guts to do this. I know I wouldn't have done, but I felt like I needed to say it. That I went up to Peter Cashpole, Head of Social Services of West Sussex, and I told him exactly what he was doing is wrong, because I was saying, look at this, these people are getting cut and it's not right. I think you and the government need to sort this out.
True. So I think the thing is, when you look at things like the health inequalities, if you look at the rate of obesity among people with a learning disability, it's significantly different from those who don't. 28.3% of people with a learning disability are obese, that's overweight, so they've got more weight on their body than their bones can carry effectively. and on their organs. That's 28% compared to 20, 8% higher. People with learning disabilities are at risk of obesity at an earlier age than the general population. Okay. Osteopenia, which leads to osteoporosis. Osteopenia can be reversed. And a lot of these reasons are about people being lethargic. You know the old sort of saying about old choice. God dear, what a load of bunkum that is. Choice is fabulous. But if you don't have the capacity to consent or capacity to make a choice, there is no choice. If I ask you to have, if you want tea or coffee, but you have no concept of what tea or coffee is, I'm not offering you a choice. But in the politically correct world of social care and healthcare that want to sort of make it seem like you've done it, oh yeah, I gave him choice, he didn't want to do that. Gave him choice, he didn't want to get out all week. Gave him choice for that, he didn't want to do it today. So they're just getting fatter, fatter, lazier and lazier. They're going to have shorter lives. You see, social model not helping people, helping to actually shorten lives inadvertently with the best will in the world. It's not happening. The reality is, if you're taking someone to an appointment in a hospital, make sure that they have that appointment, because that appointment could be the one that leads to shorter life for that person. Don't go away without having that done. The idea of giving somebody a little sedation, give them something that takes off the edge for them so you can get a blood test, do it. You'll be argued, and I've had it with colleagues saying to me, oh, I'm surprised you're advocating for a chemical kosh. And I said, that's interesting. I'm actually advocating for treatment without trauma for an outcome. It's about somebody's life here. There's nothing to muck about with here. This is the reality. Not having your appointments kills. We have to stop using fluffy words, stop nicey-nicey, love me because I'm a learning disability nurse, all that sort of stuff. No. No, 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 no. I'm in the business of doing 4 words. 4 words describe what I do and learning disability nurses like me do. We enhance and save lives. That's it. There is nothing else to it. That's it. We enhance and save lives together with those with living experience and other colleagues working alongside. It is about supporting all of us. It's about modelling and shaping. It is about us all being responsible for our society. Again, is this a developed country? Is this a country in which people's rights are really accepted and people have what they need to have? And how is the society judged? Is it judged by what a Prime Minister, who's really quite weak, says, Cabinet says, government says? Interesting about will of the people. Funny that, isn't it? Will of the people. When you had 1% and you actually gave a binary choice, yes or no. Well, is that really good much choice? Is that really a sensible thing to look at? Now, political things aside, I have my views on that, clearly. But the point about that is that's interesting. You go on about the will of the people to listen to the will of the people for that, government. But what about the will of the people to enable those to have the lives that they should have? What about the groundswell that we've heard about Gosport in the hospital, that things happened there? What about the things and the shift and change that we had after what happened in Stafford? What about those things? What about the horrors that are happening for people with learning disabilities? And that's what we've really got to get across to people. Nicey stuff. Valuing people. Wonderful document. I and others at the time thought it wasn't much good. Lovely phrases, brilliant, loved it. What was it ever going to do? I'll be nice to Andrew because he's a good bloke. Really? It was a good philosophical basis, yes, and it shifted some way. But what it didn't do is it didn't have teeth to make things really change. People weren't being penalised. Money being taken away from their service. People being taken to court for not delivering on the care. And until we really have those things happening, are we going to see a change? So, if you then look at, in 2007, the direct cost of obesity to the NHS was £7.1 billion. By 2050, the cost to society is predicted to be over 50 billion. Massive. And when you look at it, 28% of people with a learning disability, 8% higher. So we know the problems and we know the solutions. So what are some of the solutions? What do you think of the solutions are, Andrew? What do you think some of the things we can do to make it better? What are they?
Well, things we need to do with doctors or NHS staff, I think they need to have more training to help them know how to help people with learning disabilities, and making sure that things are happening, because like when I used to work, I used to do a QT quality checking at Southdown Services, and well, the thing we had to do, we had to go into the services, check the services, make sure they're all good, and also making sure that the quality was good for the clients, make sure they were getting what they want in their lives. So basically, what's quality is basically, say like I could say I like Leicester, but then it's different for Jim because he says he likes West Ham. But see, there's two different things, and it's like the quality of that person. And what we want to do is do it in the same way, but quality for the NHS as well, to making sure that we are getting enough care that we want.
Very true. And some of the things that you talk about and training, it's really interesting because the idea of having 2 days mandatory training for induction in health services that some are talking about now, it's not going to happen. It's not. And it's not going to happen because people don't want or care about people with learning disabilities, so that's very, very different. The thing is, if you have 2 days for learning disabilities, 2 days for epilepsy, 2 days for this, 2 days for that, your staff are never going to work. They're just going to be doing training. The best way to get education through is actually to make a reasonable adjustment, and that is to have the learning disability nurses working alongside others to model, show, demonstrate, and have throughout every program. So if you're doing your update on epilepsy, for example, there's a case study of somebody with a learning disability in there. You're doing diabetes, the person that you're referring to has a learning disability. So embed it throughout. That makes change. That really does make change. So what are some of the reasonable adjustments under the Equality Act of 2010? Well, some of them are things like double appointments. Yeah, okay, that can happen. Some of the easier, quicker and cheaper ones to do are things like environmental changes. So where I work now, we have dimmer switches in all areas. So you can turn the lights right down or right up. Why is that so good? Because it's not all about people with a learning disability or those with autism. Reasonable adjustments are for anybody who has a disability that is defined as one under the Equality Act. So if you've got someone who's visually impaired, you turn the lights right up. If you've got someone who doesn't like visual noise, you turn it down. Straight away, that interaction has changed. And how much does a light switch cost? Not a lot of money. But you've changed that automatically. Really good. Buzzer systems, we've got those in the hospital I work in. Brilliant. So it means that if, let's say Andrew comes in and he doesn't want to wait with everybody else, and he wants to go down to the coffee shop next door or sit in the park, he can do that as long as he's in a 10-minute radius of the hospital. And then what happens is if he steps out, it does another buzz like that, so he knows to get back into the area, because you're not always going to know. Great, isn't it? And it tells you you're next. Wow, fabulous. Isn't that a simple solution? Again, not a lot of money. We don't have to be talking about huge amounts of money. Videos. People with learning disabilities don't express pain in the same way as other people very often. So things like the pain tools that are in hospital, most of the time they're pretty rubbish for people with learning disability. So one particular person we had who I was working with, he had pancreatitis, and he used to curl himself up and put his head between his legs when he was in pain. And then you give him the morphine. Fabulous, great, okay, he's having his treatment. The problem with that is the side effect of that is much more dopey, much harder. So his quality of life and experience at the time is diminished. So with his mum, mobile phones, again, we'll summarise the key takeaway messages. She videoed when he was good and when he was not good, okay? So 10 seconds, that's all we had. So we videoed it and we looked, because he didn't have much of a facial expression change. He had severe learning disabilities, no verbal language. What we found was we could look at the clip where he started to change, when he started to do that. So that's when we gave him the medicine, okay? Gave him a high dose, relatively high dose, but it brought him out quicker. He didn't have the side effects, and he hadn't had to go all the way through that pain and trauma. That's what learning disability nurses do. Now, the mother of that particular child wrote with me a chapter last year called Refocusing, All We See Isn't All That There Is. And do you know what she's doing now? Yes, she's a learning disability nursing student in her first year. And her husband, who's an accountant, wants to change. Once his wife has finished the training, he's going to go on and do it in their son's own name. That's a fabulous outcome. Unfortunately, their son did die, had a life-limiting condition, very, very horrifically sad for them. But sadly, that was always going to be, unfortunately, the outcome, really. It was just a matter of time. But it was about giving quality of life and support. So some of those things are really good tools to use. And coming in with video diaries, with pictures about what Andrew's like when he's really well. Because when Andrew's not well and when I'm not well, I'm not the same as I am sitting in front of you. You wouldn't, would you?
You wouldn't be the same at all.
You won't want to be going out to a gig, will you, in the middle of the night when you're feeling rubbish? And you'll be a bit more irritated?
Yeah, because I wouldn't want to do that, 'cause if I feel ill, then I would need a lot of support for it, because it can be a matter of life and death with diabetes. It's life when you've got it. And like when you've got these football players, right, and you think, God, they're earning so much money, why can't you put this money to NHS? Why can't you do that? Instead of paying all this sort of money to these football players. And it's like, and also, I think what should happen is like, what has been happening lately is that with NHS, we have something like a health action plan. So it's like an easy read, so we know, so because I have a learning disability nurse and she checks out all different things that's in the health action plan to help me out.
Yeah, really important. Things like health action plans, annual health checks, they save lives. It really is. Let's stop fluffing around and woollying it around. We've got to really hit where the reality is. And health action plans and annual health checks can save lives. And I think when we look at trying to shift views, the costs of not doing this are just phenomenal. And people talk about, you know, the cost of this, the cost of that. It's the cost of lives. It's also the financial cost and the drain on society that brings. But it's like, it is not hard. We know the solutions. And we can get the change to happen. So I think there's other things to look at. I don't know why these slides just don't seem to come up on the screen at all, and they're just stuck on one, but there you are. I don't know if the IT guy's been around, but anyway. So making reasonable adjustments, really it's about a teach approach. So it's time. Take the time to find out what you need to do for that person and with them. And what time do they need as well? People will tell you it's much harder, it's much more costly to do double appointments. Well, it's a lot more costly when you get sued because you stuffed it up. And when you get taken to court and when someone dies avoidably. So a bit more time, build it in, it can happen. The environment, alter the environment, so that's the E, alter the environment, quieter areas, reduce lighting, all the things we just talked about. A is the attitude, have a positive solution-orientated focus. So if someone's coming in to see me in clinic, they're going to get what they've come in for. They're not walking out that door unless they've got it. I mean, if they really don't understand what's going on, and it can be delayed, like the Mental Capacity Act, you can delay, you can leave things if they can be delayed, but very often that's not really a genuine option. Hiya, how you doing? I'm not very good at IT, you can tell, you're brilliant. So we've got stuck here. I wanted to get onto that slide now. Oh, wow, that's because I wasn't in the right program. Okay, there you go. God, I've got to be in the right window. Am I in the right window now? Yeah, I'm in the right window. Okay, you see where we are. Ah, lovely. So this is the slide of the campaign and the movement. It's not really just a campaign, it's a movement for shifting thought and shifting change, which is going to be formally launched next Friday by Sally Phillips and I. So we were at the Supreme Court yesterday with quite a number of different people there, which we'll talk about another time. So what this is really about is giving people tangible things to do so that there will be cards that are produced that people can have. There's going to be a website with material information for people to take away. There's things that we want to see. Like, you know, you've got Admiral nurses, you've got dementia nurses. Why don't we have learning disability nurses? Why I'm working with organisations at the moment that have things like that to set up frameworks for LD nursing. That's what we need to be giving people so that when I'm saying if you've got diabetes, you have a diabetic nurse. Why aren't we saying if you've got learning disabilities, you have a learning disability nurse alongside others, but making it a reality for people? Things like, why don't we have a call centre, advice and guidance area for people to phone up that's staffed by learning disability nurses? We have those in mental health. They're called single points of access, phone centres. They're great. They save lives. Brilliant. Why don't we have that for learning disabilities? Let's work with others to build those things and make sure they happen. When you think about care providers and social care, how many learning disability nurses are really doing the jobs that they should be doing as a learning disability nurse? Registered managers of homes and senior support workers and support workers, anybody in care, do a brilliant, brilliant job. But if you've got a learning disability nurse in your organisation that is a registered manager for one home, ask yourself one key question. Is that the best use of their knowledge? My answer to that is no. The best use of their knowledge is to release them from that area, to hover maybe over 5 or 6 areas, to make sure that the support staff pick up on the deterioration of the individual when the behaviour starts to change. So Fred can ring up and say, do you know what, Jim, I'm not sure, Mohammed's not really himself today, I'm not quite sure what it is, he's not been well for a little bit the last couple of days, could you pop in and have a check? Now that's not saying that the person ringing up isn't doing a good job, I'm not saying that. It's about using the expertise, making sure that the annual health checks are taking place in those areas, making sure that there's follow-ups for appointments, making sure that they don't get cancelled because of the linguistic gymnastics from health professionals that make it blindingly difficult for most people to understand, including myself. So that's the reality. That's what we've got to push for. But it has to be a movement where many come together for that. And it's looking within care associations and others nationally. That's the drive. What's happening before people go into hospital, as well as in the hospital. And I'm not talking about assessment and treatment services. They are not hospitals. We must not confuse that, because I've had people that have said, when I worked in a South West London hospital, I've had people saying, they're not coming into hospital. Why? Because they don't come out of those places for 2 years. I said, what do you mean? This is an acute hospital. They're not going to be staying here for very long. That's the confusion of some people. And that's not helpful. And it's not helped by NHS England calling them hospitals. Call them what you want, but don't let that confusion take place, because that does take time. And it means that some people aren't getting into acute care as they need. And we really have got to act. It is about assessing what is happening to and for the person. Consider what is behind what is happening. Is there a health problem? And get away from the idea that this is somehow medicalising it. And, you know, some people say to me, oh, I see you're just moving back towards a medical model of care. Rubbish, I'm not. I'm moving to a model of saving lives, if you want to know. That's what the game plan is here. It's as simple as that. We have got to stop people dying. And we've got to take action. Don't delay it. It does honestly cost lives. And it is very, very avoidable. We've got a Twitter account that's at LD Changing Care. So at LD Changing Care is the Twitter account. That website's going live next week, by the way.
And also, with the action, it's now or never, because if you don't do it now, it might be a problem later in the future.
Very true, Andrew. So we talked about the teach approach, which is really very helpful. We've got about 4 minutes left. By the way, has this been a good session for you guys? We were hoping, you know, if you want to chip in, but it's been great because I can see you all really engaged. It's been good, isn't it? Experts by experience. So those people like Viv and others and Andrew and people, I have no idea what it's like to have a learning disability because I don't have one. I have a daughter that doesn't have a learning disability, so I'm not an expert. We in health, social and education care see that much of a person's life. And yet, so often, we think we know everything. Brilliant. What do I know about Andrew? Well, I can tell you. He's a lovely guy. He's got a great sense of humour. He likes music. He likes Leicester City. He has diabetes. And he happens to have a learning disability. Fine. Right? He happens to. That's not who he is. It doesn't define who he is. He's got a fabulous T-shirt, by the way. It says New World Order. I like that. I want to know about that.
Yeah, because it's wrestling. I like WWE wrestling. Yeah, and I've got a learning disability myself. I've got autism, ADHD, anxiety, depression, and diabetes as well. So what happens is sometimes when I feel low or something, my autism, and anxiety, and depression bang at the same time, they'll bang, and it's like I find it hard sometimes. But with learning disabilities, it's quite hard myself. Sometimes it's a lot of things you have to experience yourself with it. But it's like you want to do things yourself, but then you can't because it's like jobs out there. It's like if learning disability wants to, like say a person with learning disability wants to have a job, right, go out there, they'll turn around and say, sorry, because you've got learning disability, you can't have a job, you can't do that. And it's not really fair because it's been happening in this world. It really isn't.
Yeah, so true. And if you think about some of the hospitals that you access here, how many hospitals actually have interns? That's people with a learning disability that are doing employment work in between the age of 18 to 24. So in the 2 hospitals I've worked in the last 10 years, we've had that. The hospital I currently work in, we started last year with 5 people with learning disabilities, an intern. This is a partnership between Camden Council, City and Islington, and the hospital I work in. And last year we had 5 people. This year we've got 8. Next year we're going to have 10. And they come with job coaches and a teacher that the council employ and do that. And it makes a difference. And we're employing people. We've got porters that have a learning disability. We've got people in the post room all over the place. And it shifts people's heads. And it changes. And people then value them more. Why haven't we got them on NHS trust boards, in county council boards? Why aren't they there? Possibly because they're called board. And I think they should be called, the meeting should be just called interesting and not last too long because people get bored. Maybe that's why they're called that. But I think it's really, really important to think about that and think about why haven't we got parents and carers and people who learn this as governors in hospitals. Luckily enough, in the hospital I'm in, we do. Simon is a governor. He's got a 13-year-old daughter with severe learning disabilities. Fabulous. So he's there holding the hospital together. Brilliant to have somebody like that. Thankfully, we think quite similar, so it's not like we're conflicting all the time, because that'd be terrible, wouldn't it? But he's a really great guy. And it's about pushing, we don't always agree, by the way, but it is actually a really good way of finding out solutions together. And if you do that, you make a big difference. In your local health services, is there such a thing as LD, Our Health, Our Hospital? Where they people that use the service alongside parents and family members actually engage with helping that service to evolve, to change. Do your local health services, do they have learning disability nursing students going into the hospital? Probably not. In the last 2 years in the hospital I'm in, we've had 25. The argument for learning disability nursing and for people in learning disability care and support to get health reasons right is not hard. Believe me, people buy into it quite quickly when you offer them solutions. So go to people with problems, issues and challenges. They'll look at you and smile very nicely and you'll get a nodding donkey. Yeah, I hear what you say, I'm going to do absolutely nothing about it, but I hear what you say. Whereas if you come with solutions, they go, okay, you've got a problem, you've got issues, you've got challenges. Ah, a solution, like that. That's when you get stuff changing. It's got to be solution focused and it's got to enhance lives.
And also, what I can say is that what is good, that it's like last year when they had this conference here, I got a choice to become a co-chair of it. And because it's very good, because like what Tom said to me, he said we've got to have someone who's got learning disability who would love to co-chair and actually see for it how it will work out. And it's now my 2nd time this year.
Doing a brilliant job. So these are the sort of things, when you look at a summary of what's going on, it's quite nice to have things that are small, that are simple to do. So beware of missing serious illness. If someone is behaving in any way different from how they usually behave, don't put it down to, oh, it's just a bad day. It may be, but consider. So monitor, is that just a bad day that Jane's had? Oh, she's had a bad 5 days now. Oh, she's had a bad 8 days. Oh, dear, it's now 2-3 weeks. Don't delay. I've had cases of people coming to A&E, they've fallen down the stairs 3 weeks previously. Didn't go to the GP. The person started not to eat. They got very, very skeletal. They weren't very large to begin with. They came into the hospital I was working in, and myself and the treating A&E consultant looked at each other. There was nothing we were going to be able to do for this person. Their hip that had broken had been fused. They were too weak for the anaesthetist to anaesthetise because the anaesthetist would have killed them. The orthopaedic surgeon I spoke to said, I can't do it because he won't anaesthetise. But anyway, I couldn't anyway because I'd have to re-break the bone. They're not strong enough for that. I said, if they'd come in 3 weeks before, could we have done something? Oh yeah, they'd have still been a bit too weak in terms of their body weight. They would have had to feed them up, but we could have done that with drips and other food substances. We could have got them stronger. But the point was, we could do nothing for that person other than try to make them comfortable, and they died 5 days later. Was that death avoidable because of the hospital? No. Sadly, not. And we went through absolutely everything for that person, but we couldn't do it. Another case. You've all heard probably of Carl Flack, who snapped his neck in Cottsides in Basildon Hospital. In the acute hospital I was in before, we had a 22-year-old guy who came in. He's got severe learning disabilities, no verbal language. His mum's about 5'4". He started trashing the house, computers, breaking all of this sort of stuff. He had never behaved like this before. He had epilepsy, but this wasn't anything to do with that. So he came in. Thankfully, there was a switched-on GP who did partly sedate him before he came into the hospital, which was a really good move, because this guy would not have tolerated being in the hospital. Do you know what we did? Put him in a side room in ITU, put mattress on the floor with pillows all around. In ITU, the ratio of consultant to patient is 3:1, normally. Made it 2:1, and that person was nursed by the nurse in charge, so the sister or the charge nurse. Okay, so you got really good treatment for him. He was sedated, ended up being in for nearly a whole week. Why? Because under the Mental Capacity Act, he lacked capacity. We had to try to find out a health reason behind what was going on, because we had no idea what was going on. I rang around, spoke to community colleagues, the schools, colleges had been at, spoke to his GP, spoke to everybody who could think of, spoke at length with his mum the whole time, who was very anxious, obviously, and understandably very distressed, but realised we were doing all we could. The reason it took a week, because we didn't believe the tests we were coming back with. We checked him, everything top to toe. We couldn't believe there was nothing, so we thought, hang on, we better check again. So we did. Then eventually, we'd done all those checks. You can't keep him sedated just because you can't. It's not lawful. So you bring him out, of course the behaviours come up again. Where else is he going to go? So he ended up going to a mental health unit, and he was sectioned, and his mum was content. She wasn't happy. She was very distressed the whole way through, as you would expect. But she knew we had to do this, and she was in agreement with it. He stayed there for a week. Behaviour dissipated. No problems at all. And he wasn't mentally ill. It was it was a mental health unit where there were learning disability nurses and learning disability psychiatrists, specialists there. Behaviour dissipated. No problems. Went back home. Behaviour increased again. Didn't come back into the acute hospital, didn't go to the psychiatric hospital. Went to a respite service, behaviours went down again. Went back home, behaviours went up again. Wow, this is a really tricky situation. So what the end product is, this person then moved away from home, lived nearby. The relationship with mum and everyone else is much better. His behaviours are much more reduced at that point. The only summation you can get is that this man in his early 20s wanted to move away from home and wanted his space. Then still got a very good relationship with his mum, but actually didn't want to reside there anymore. Now, ask yourself this. If you'd come into an A&E, into a hospital where there hadn't been a learning disability nurse, would his journey have been that? Answer, no. What would his journey have been? Very, very different. So that's why we need to do what we're doing to fight for the rights of people with a learning disability, to make sure they get the care and treatment right. If you don't know the law, how can you make that care happen? We were justifiably keeping him in the hospital because we were actively looking for a health reason behind that. Why did he need to be sedated for the week? Well, because he wasn't going to tolerate any examinations otherwise. Is there real risk for him harming himself and others? Yes. Is he mentally unwell? Well, we don't know. Don't take him down the psychiatric route straight away. Let's look at a physical health reason first. You do that, you bring him up, you then have to use a different piece of legislation to support him. But it was always just to do the immediate. It wasn't going to be for a long time he was there. And then it was always going to be followed up. So it was very carefully planned, and it took a lot of work to do that. But that's what we need to do. So I'd like to thank you very much for listening and being so engaged. Over to Andrew before we finish.
Yeah, and I feel I really felt that's very good because it's like you were saying about that person, Lesbian, who had no like really challenging behaviour. It's like what happened to me. I felt a bit like that at one time, and that's when PBS, positive behaviour support, came in, and they found it. They what happened? They were checking out my support, and then they helped get the staff to work more better around me. Because there were certain things where my support wasn't going right at one time when did that. And also sometimes, say like if you're going to hospital and you've got learning disability and they're going off anywhere and they sit with a doctor, you've got to think, right, from top to bottom, you've got to think, right, what's causing this? You never know, they might have autism or they might have ADHD. You have to find out where it's going from because different symptoms can cause a lot of things. Like, say like if I'm like in my diabetes, if I get in a mood, yeah, it's because either my blood sugar's low or it's high, then I can change in different moods. So this is why you have to get these nurses or these doctors to help you to realise how easy it's going to be to help for that person.
Yeah, very true. We are into the coffee break, but you've got until 11:50 for that. So if you want to have 5 minutes of a chat, anybody got any questions now or other times? I do work in one particular hospital, but I don't discriminate against any other hospitals, any other services. I don't care. As long as somebody's got a learning disability, I'm happy to help wherever they are, whichever country in the world they're in. I'm not interested in that. So I'm always happy to help if you think I can. And you'll always get an honest answer. So if I haven't got a clue, I'll tell you I haven't got a clue, but I'll try and put you in touch with other people. So do use people and challenge. It is worth fighting people for the rights of people because it's about lives. Yeah, you do. Okay. Yeah.
The person got sort of spent most of their time doing safeguarding training, but the post this lady's going to be doing is actually combines both doing the kind of work that I think you're doing, but also I know that Karen, who was the safeguarding lady, has got a rolling ongoing programme of training the nursing and medical staff there.
It's really important. I don't like the term liaison nurse. I don't get it. I don't really know what that means. And that's the problem, because our acute colleagues haven't got a dicky bird of an idea. That was a real shambles, that idea that the setup said, well, we'll have liaison. Why? Call them clinical nurse specialists for LD. People get that. That's why when I appointed the CNS I have, she's a clinical nurse specialist. She's not a liaison nurse. Because people would just go, well, what does that do? Does that mean Phil just rings people up and has a little chat and liaises with them? Well, we don't know what that means, so we won't really use that person. That's why posts disappear. That's the tick box exercise that hospitals will do, because they don't really want that person in post. They can get rid of them quite easily. You have CNSs for epilepsy. You have CNSs for diabetes. You have CNS for chronic fatigue. You have it for loads of other stuff. So why don't you have them for LD? Let's scrap the idea of liaison. It does not have a meaning in acute service settings. Nobody gets what that means, but they do get what CNS is, and that's why it's important. And I'm a consultant nurse in learning disabilities, and sadly, there's only two of us working in acute hospitals in the country. And in 2008, I was the first and only one, and until 2014, that was the case. The other one is Joanne Kiernan at Alderhay. So, which is a post I helped create. But the thing about these things is this is what we can achieve. You can create significant change. You can get involved. The idea of I can't, I won't, and I'm not going to, that just permits death. The idea I can, I will, and I'm going to change, that provides solutions. So do the latter, don't do the former. And when we're articulating people, always, always, always use the fiscal case. Use money. You'll save lives, but you'll save money. You do it this way, you'll save time, you'll save money. You do it this way, you'll save time for staff, and you'll save money. So having LD nurses working alongside it, funnily enough, you're going to get better treatment. Okay? You'll pick up earlier symptoms. You'll pick up things quicker. So it'll save everybody. Yeah. Any other questions or any other comments that anybody's got in the sort of 3 or 4 minutes we've got left? Yeah.
So I'm on the same team as Rosemary. So we've also been supporting GPs. We've done a pilot scheme with some of the GP surgeries in our area. Hopefully we'll do more. I think it's a great idea where we go along and, you know, making reasonable adjustments. We were talking about that. So I take somebody along, I go through everything with them, and then I go into the GP and give a little synopsis before the GP sees them, and it's really, really working well.
So one of the things that's a challenge for you guys is that excellent practice. The problem in learning disabilities is they talk to the learning disability world. I rarely come and talk at learning disability events, and I never publish in learning disability journals anymore. That's not because I have a dislike. It's because actually, if I'm publishing in the Journal of Family Medicine, which I do quite often, it means that all the family practitioners, GPs, and all community and primary care, they get it. That's a big hit. If I publish in acute medicine, people read that aren't LD specific. These are people that don't necessarily know about the issues, so they read it. So make videos, post them, send them to me, and we'll stick them on the website. We'll make it a resource. We'll make sure that people get celebrated, and it's about a movement for change. Campaigns come and go, movements don't. A movement for change that really drives forward, and that's because we're no longer going to accept deaths. We're no longer going to say it's okay. It never has been, and it never will be. But otherwise, when are we going to actually do it? So you think we've emptied this room by next Wednesday? That happens all the time. So who do we choose has a life that isn't worth living? Oh, well, people wearing a stripy top. Yep, you can go. You can go, you're in dark blue. Spotty one, yep, you're off. Okay, that's all right. You three, you're right for today, but you're gone tomorrow. You know, what is this? That's not exactly quite how it's happening, obviously. But if you think about it, if you distill it down, by not acting, we are permitting. Inaction costs lives. Action saves lives. If you're not going to act, make it an active decision not to act because it's in the best interest of the person not to do so. That's a totally different thing. I'm not suggesting that. But if you suspect that Matt's not been himself today and he's not his usual self, let's say I'm picking on Matt, would you just sort of go, oh, well, that's just Matt, you know. He does that for two days. He now seems to be getting a bit worse. He's now poking his eye. He's now hitting his jaw like this. He's now gone silent. Or he's screaming a lot more. Do we just sort of ignore that and go, well, that's just Matt. It's just what blokes that wear you know, nice black short sleeve shirts. That's just what they get up to. It is important. Yeah. Yeah.
Acute medical journals. But I suppose the other way of looking at that is how many learning disability nurses get to present at, you know, the conferences for, you know, that doctors and people go to in those specialist areas.
Answer to that is not many. You know why? Because they don't put themselves up for it. It's extremely easy, and you can get. Hey. Okay. Yeah. Just you find it, yeah, it's quite tricky to find an issue, but once you start looking around, you find it, put yourself up for it. They'll say yes more times than no because they want to have somebody up there. They want to have different topics to be talked about. And it is, you know, there's a groundswell of genuine shift. So I think if you put yourself up for a dental conference, you want to talk about dentistry, get in touch with the British Dental Association. If you email me, I'll put you in touch with the chair and you can get it sorted and you can go and talk at those. That's the sort of stuff. So use people that you know. If you want to talk at an event and you can't find out where it is and you want to talk about a specific topic, let me know. If it's diabetes, you want that, British Heart Foundation, right, we'll just email them and say, right, you want to talk about this, you've done this project, get on with it. Don't sit back and go, well, I don't know where it is. Because actually you've got the internet. Okay, maybe not today because the Wi-Fi is not up so much, but but you know what I mean? There's a lot of stuff out there that you can use. And I was being a bit I do occasionally publish in the learning disability journals as well because that's important, but it is important to do other things as well, not just talk to the learning disability community talking to each other, because that's just about, you know, talking to the converted. I mean, what's the point of that? You wouldn't find Billy Graham just talking to a bunch of converts the whole time because he'd be pretty out of a job pretty quickly, wouldn't he? Any other comments? Positive, negative? All right, you all think England are going to win the World Cup. How about that, Andrew? Vardy's going to score a hat-trick, isn't he?
Yeah, the last thing I'm going to say is that basically with every action there's always a consequence, whatever action it may be. And also give one applause to Jim because he's done very well in his presentation.
He's a nice man, Andrew. That was very kind of him. I did slip him a tenner earlier. But Andrew, I think you've been absolutely fabulous. To talk about your own experiences, to share them in so much detail, it is really not easy to do, but very powerful because that's the experience people really take away from. So, and thank you all very much for being engaged and engaging, and all the work that you do really matters. And it is about every day when you think you're a little bit fed up about going in and working with people, think about what a joy and what a privilege it is to tap into someone's life for those moments, because it really is fabulous. It's such a lovely opportunity. And I would never get bored. I never understand how colleagues work with people without a learning disability. I don't know how you work with those sort of people, because people with a learning disability are far more fun and far more engaging, and you have a lot more fun doing that than, God, I don't know how they work with people without an LD. I really don't. I couldn't do it. So it's fabulous that they do. And they do so well for those sort, don't they? They you know. Don't be apologetic. I mean,
Okay, so you gave us the acronym: TEACH, time, environment, attitude.
time, environment, attitude, communication, and help. Help is the help you need and the help that that person needs as well. Yeah, that's when it came. So if you're interested, there's a, if you are interested, you can Google, if you Google my name, put learning disability beside it, you'll see a lot of publications I've done. If you go to the intellectualdisability.info website, nearly all of my publications are up there. So get that, and it talks about that, it gives you case examples that you can actually take it. A number of families actually do take those to their appointments with them and say, actually, you know, you say you can't do this, well, actually you can. And that's when they see it in a peer-reviewed journal, people actually do pay a bit more attention, sadly. But it's important. So, Google what, Jim? You can Google what, Jim, if you like. You probably get up with some strange things, but just put in Jim Blair learning disabilities. You might put Jim Blair, lots of other things in there. But if you follow me on Twitter, @JimGBlair, I regularly retweet the stuff. And the best things that I've written are things I've not really written much about, so I'll talk to you about some of them. So Through Our Eyes, What Parents Need and Want from Health Professionals, I wrote with 6 parents, and it's an absolutely brilliant piece of work because it's their words, and if you knew them, their words have not been changed, so how they speak is how they sound. Every time I read it, I can tune back into those people and those conversations. Refocusing, All You See Isn't All That There Is. That's about getting care right in hospitals and healthcare. And if you go to www.intellectualdisability.info and just type in Jim Blair, you'll find all of those. And that I wrote with 3 of the authors up there: Yvonne Newbold, Kira Lawrence, Ishmael Kaji, Ishmael talking about what it's like to be a parent with a learning disability, and Loretta Olafаю, who I told you about, her son and Simon. So that's about what it's like having a learning disability coming into hospital. And I'm writing another one with 4 people with a learning disability and 3 parents, and that's about Understand Me. So it's about mental capacity, but also about the person. And they're much, much better to get the lived experiences of people. The other things to come across is, I don't know if you've looked at Pavilion recently, for £5.95, I don't get any of the royalties. The royalties all go to Vicky, who's my co-author, who really wrote it all, Vicky Ainsworth. And one is about how to get diagnostic information wrong, and then what to do about it. And the other one is how to get healthcare wrong for people with learning disability and what to do about it. And it's written from a lived experience, from her experience of having a daughter who's 21, who's got severe learning disabilities. And Vicky and I were at school together, so we've known each other since we were 12. So it's really nice to be able to do that work together to move stuff forward. So you can find that, and it's £5.95. It's not a huge expense. They're nice little pocket guides, yeah. So just keep on being brilliant, and have a fabulous day. Shall we turn it off now?
Yeah, turn it off now.
live stream. Oh dear. Okay. Right. Sorry. So the Challenging Behaviour Foundation is a small but national charity. It focuses on the needs of children and adults with severe learning disabilities who display behaviour described as challenging. So the combination of those two things, the severe learning disability and the difficult behaviour. We provide information and support to families and professionals who are supporting both children and adults. And if you go on our website, we've got a whole range of information. All our information is free for families. And we have three main strands of work which are all interconnected. So the first is information support, which we have through our website. We have information, leaflets and DVDs, all focused on very practical information. We have networks where we put families in touch with each other because families feel very, very isolated. Equally, professionals feel very isolated, so we have a professional email network. We also have helpline support for families, and we do casework. So we have a person, two people at CBF who can provide individual telephone and email casework for families, because often the issues are long-term and ongoing, and sometimes things are going well and sometimes things not so well, and people sort of come and go in terms of our support. We also, our second stream of work is strategic influencing, because we quickly realised that we can help people on an individual basis, but there are lots of common themes, and so we can achieve more by trying to work strategically. So we have a strategic influencing strand of our work, which is informed by what families tell us, their lived experience, and we work with government, with the regulator, with providers, a whole range of people. Because in order to get it right for this group of people, we all have to understand what their needs are. We all have to understand how to support them in order to get the outcomes, which is a good quality of life for people. And then our final strand of work is sharing best practice. And that obviously links to families, so we share that information with families. Families share it with us, but we also try and use that in terms of strategic influencing, in terms of being solution focused. So that's the work that we do, and at the Challenging Behaviour Foundation, we think of behaviour as a symptom, an indicator of an unmet need. And one of the first things that we talk to families about when they contact us is to say, has your child or your adult relative had a recent health check? Because very often the behaviour is indicating an unmet health need. And quite commonly that doesn't happen. And then the other thing that we really focus on at the CBF is working with families. Because of my own experience as a family carer, but also because families can provide a huge amount of important advocacy for their relative. They're lifelong. My son Daniel has had hundreds of people in and out of his life. He's 32 now. He's had hundreds of people who've come into his life and who've been really, really important to him, but mostly they've come and gone, and we're still here as his family, and we always will be. So we're able to provide that consistency. We're able to be person-centred. We're able to be holistic. We're able to provide information about his history and experience that most people don't have. You might be able to get it from a file, but actually, you know, we've lived alongside him and with him, and so we are a valuable source of information and advocacy. And so if you ask families what they want for their relatives, there are three things that they say they want. They say they want information, and they want information that's accessible, that's practical, that's timely, and sometimes they need information, help to use the information. The second thing they say they want is they want good support for their relatives. They rarely talk about their own support needs, and if you ask them about their own support needs, they say, well, if you get it right for my son or daughter, you get it right for me. And the third thing they want is to be valued as partners. So, as I said, you know, my own experiences with Daniel is that I'll always be part of his life. I have a huge amount to contribute. I firmly believe that he wants me to be part of his life, and families are important to all of us. So why should it be any different for Daniel? So in this workshop, we're going to be thinking specifically about accessing hospital care for individuals, children and adults who have severe learning disabilities and who display behaviour described as challenging. What we're going to do in the next 40 minutes is I'm going to divide you into 3 groups. So hopefully you'll all move about and get into 3 sort of broad tables. And I'm going to give you some case studies, and I'd like each group to look at one of those case studies and think about the issues. And we're going to have about 15, 20 minutes to do that, and then we're going to feed back. So could you please, the first challenge is to get into 3 groups, and then I'll hand out the handouts. Okay, thank you for doing that so swiftly and efficiently. Hopefully everyone's got a copy now or sight of a piece of paper that's got 3 case studies on. So these are anonymised versions, and sometimes they're a bit of an amalgamation, but they are all situations that we have supported families through at the Challenging Behaviour Foundation. What I'd like you to do is for this table here to look at case study 1, which I think was William, and this one case study 2, and this table case study 3. And you sort of look at read the case study and discuss it, and there's questions at the end. You can have like about 20 minutes to look at that, and then no, actually have 15 minutes. 15 minutes to look at that, and then one of you feed back to the rest of the group. Okay, does everyone know what they're doing? Okay, great. Okay, we're going to start the feedback now, if that's okay. Shall we traditionally start with group number 1? Okay, I'll just read out the case study because the other groups may or may not have read out your case study. So group 1, we're thinking about William. So William's a lively, active, sociable young man in his late 20s, has severe learning disability, no verbal communication, and displays a range of behaviours described as challenging, including self-injury, PCAT, and disruptive behaviours. He became a bit subdued, went off his food, usually has a good appetite. He was taken to his GP, who suggested he went to A&E for an X-ray. At A&E, his support staff explained about his behaviours, that he was not himself, although that to others who didn't know him, William was seemed fairly ordinary and compliant. He was sent for an X-ray. Doctor diagnosed constipation and prescribed laxatives. After a few days, there was no improvement. He was taken back to A&E and X-rayed again, told again it was constipation and to take more laxatives. At the insistence of his family, investigative procedures were carried out under general anaesthetic. William was found to have multiple items in his stomach and required emergency surgery to have 3 kilograms of mixed materials removed. Okay, so the questions were, what can be learned and who were the lessons for from William's experience, and what proactive, reasonable adjustments could be made for the future?
So we talked about a number of things for this case study. They actually take form of questions themselves, to be honest. So first of all, we're kind of wondering about what form of communication William uses. So obviously it says he was non-verbal, but what kind of strategies did the home use to communicate with him? Are there pictures? Are there kind of cue cards? The other question we had was around, obviously PICA has been identified as a behaviour. So is there a care plan? What are the risk assessments around that? And as part of that, thinking about actually kind of food charts and bowel charts to be monitoring what he's having. Because if they were doing that maybe earlier on, then maybe it could have avoided what was a really traumatic experience. And as a whole, just we talked about kind of more thorough monitoring of health needs, and maybe also thinking about kind of second opinions, because obviously kind of there were some issues around this kind of initial doctor, and maybe actually thinking about what kind of complaint procedures would be, just to kind of think about how it was approached, because obviously there was a delay in getting William the care that he needed.
So that's if you've got supporting staff, so they've got a clear awareness of what PICA is all about, and sort of the risks and why somebody might experience PICA, and introduce daily environmental checks so that you're sort of trying to minimise the risk of the person consuming something that could cause them a risk.
Anyone? I think the other key issue is around thinking about proactive adjustments for the future, so that when if William goes back to the hospital, that there's a flag on his records, that there's an immediate sort of acknowledgement that it probably isn't constipation, it's probably something that he's eaten, and also training for the hospital staff around, looking at the symptoms. I mean, I think there's a whole range of issues. This is a situation that I know quite a lot about in terms of this case study, and so there's a whole range of issues around the X-ray not being properly looked at, and it not being identified that there were issues. Yes. 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 And so in this particular situation, what happened was he had an X-ray in A&E, the x-ray came back, the A&E doctor looked at it and said, oh, there's this sort of major mass that will, like, you know, this, it looks like constipation. But actually what had happened was when the radiographer had looked at it and done a report, he'd said, this looks unusual, you need to investigate it further. But because the hospital procedures weren't robust enough, when the radiographer report didn't get, you know, beyond his records, and even wasn't available when he went in for the second x-ray. Yeah. So it was, so there's lots of learning there. And as you say, there's lots of learning for before it happened. So, and I think it's an indication of a whole range of issues, because, for example, so often people will say the behaviour has increased, and so that's a sort of danger signal. But for some people, like William, his behaviours decreased in that he became very subdued, and so then that's it's easy to overlook that because he's not being difficult. He's just sitting quietly. He's not indicating pain. So I think there's a whole range of ways that we need to think differently sometimes, and not just think it automatically this is what it is, and particularly to listen to the sports staff and people who know them well. Okay, so moving on then to Tom, that's this group, so we've got two spokespeople. Okay, so Tom, over the years, Tom has had traumatic experiences when travelling and in medical settings. His autism has always meant physical contact with others is difficult, but now he's not able to tolerate anyone touching him. These issues make it extremely difficult for Tom to have home visits from a GP or to get to hospital for appointments. Tom has not had a health check for several years. He takes antipsychotic medication that requires regular blood tests. He's non-verbal, cannot express feeling pain or illness. However, his behaviour has indicated he's been in pain for some time, possibly in his abdomen. Planning's been underway between family, support provider, various health professionals, including consultant and anaesthetist. Tom's level of distress would be so high going into hospital, it's thought he would need sedation from the point of leaving the house. This has not been done in this area before. Tom really needs to go to hospital for investigations of abdominal pain and for a full health check, including a dental checkup. He may need some procedures or dental work done on the spot. And the questions were, what could be done to enable Tom to go into hospital in advance and on the day, and who should be involved and who should lead the planning so it happens promptly?
Okay, well, I'll just make a start, but there's lots to consider in terms of planning. I think the first thing we were thinking about was whether Tom had capacity to make decisions about his health support and interventions, and complete a capacity assessment, and if that meant that he lacked capacity, then we'd be looking at best interest decisions involving those key people. So his family are heavily involved. There's also hospital and community health professionals, I assume. So I guess it's about having the right people involved. It might think about speech and language therapy to support with his communication. We each had experiences similar to this in terms of making sure that there's pretty much a military style of planning with lots of rehearsal. So thinking about going into hospital in advance, lots of rehearsal around that, making sure that Tom's comfortable with planning which is graded, using communication tools that are accessible to him, making things familiar. So perhaps bringing personal belongings or favoured things along to the hospital as well. So just there's many things that could be considered, obviously, in terms of the Mental Capacity Act, thinking about least restrictive interventions as well. I'm thinking longer term, you know, if Tom is not keen on blood testing, maybe a lot of work around desensitization, around procedures like that. Lots of engagement with the GP, so because he's not keen on home visits or physical contact. So hopefully getting a really friendly GP who will work with you and come in very casually and build up some rapport before thinking about any sort of physical contact. So yeah, there's just a lot. Experiences I've had is working with a community learning disability team in Brighton on the hospital services for somebody with an autism diagnosis who was very fearful of a hospital. So we spent weeks of meetings, quite intense meetings and planning and this included dress rehearsals with the paramedics, so the person was clear about the route they would be taking, for example. So lots of building up to the actual investigations, and it can often obviously result in quite successful outcomes for people. But unless you think about the worst case scenarios, you can't plan for those. So I'll pass over to other people.
So I was just thinking, you know, if we had a, God forbid, a car crash outside, we'd have police, ambulance, fire brigades, helicopter, the hospital be prepping. All of that really serious stuff can be done on the cuff, off the cuff. We're really used to doing that. I was talking to Jen, who has had to try and organise stuff like this before. So we can do it in an emergency, but I think the issues that I kind of picked up from you is that convincing people that this is important and serious and the only way to do something, without letting it get to the point where it's actually an emergency, which might be too late, and the kind of the pressure and the burden and the kind of the fight for parents and carers or whatever to demonstrate to people that this is important, this is serious, this is the only way to do it, and actually get out of your little silos and work together and put a package together, which is very challenging for people who are working in teams or services where they've got a strict remit of what they do, to then, you know, it takes a little bit of working outside the box. And I think, I would guess, in most cases, the pressure to drive that goes back to probably the parents or carers, which is unfortunate.
acute liaison nurse that coordinates everything. But I think this was a few years ago now, and I think there are less of them around now.
We've had similar things down in Kent. Not particularly. We've had similar situations down in Kent here and there, and most of the time, not always, but we've managed to link a matron who's a senior experienced community anaesthetic nurse with the consultant anaesthetist. So we do quite a bit of hospital car park anaesthesia in using those two people. And we've also had an unsuccessful attempt at using sedation at home, which didn't work. But we're ongoing with desensitisation programmes to try and be proactive for the future. So it's still on the books, even though it didn't take place at that point in time. And his symptoms seem to have decreased, so it's not an emergency, but we're still working on it for that very reason. Because it will do at some point, yeah.
Various guidance, and I think maybe including the recent leader report, make recommendations around people having local health facilitators if they have multiple conditions, but I never see that in reality. So maybe we need to find a way of forcing that to happen.
I think as well, not everyone has family. It's wonderful those that do, but not everyone has family, and they're just pretty much,
More vulnerable,
yeah.
Over to you. Do you want to say something about that?
Thank you. Just to add on that, I had a service user in the community, and the carers, from the managers, they failed to take him to the hospital because he was very anxious. On the day, he just like starts tantrums and all that. So they failed to do any annual health checks, anything like that. So he got referred to me, and I said to them, okay, we're going to work as a team. He doesn't have family, so we're going to be the people that, are going to be working with him. And with the process, it took us about 3 weeks, and the doctors involved, lots of different people involved. We had a meeting, and we were so successful. We took him to the hospital with a lot of reassurance. We didn't even have to sedate him whatsoever. But it took us about 3 weeks continuous, going to see him, talking through this, and then we succeeded in the end.
Okay, so the last group, case study 3, just going to get was Anita. So Anita's a young woman who lives with her parents, has a close relationship with them. She has moderate learning disability and epilepsy. She goes into hospital for a recurring UTI, has some additional tests. The doctor suspects she may have sepsis, so she's kept in overnight. Anita finds staying in hospital very distressing, but her parents stay with her, keep her engaged, and only leave when she's asleep. The following day, nurses struggle to communicate with her about how she's feeling, her personal care and medical treatment. She refuses to take her epilepsy medication from the nurses and misses several doses. Anita has a serious seizure, has to go into intensive care. When she's recovered a little, her parents ask for a side room for her. They're told the side rooms are reserved for patients with infectious diseases. Anita starts to move about within the intensive care ward, pull things off the wall. She's deemed a risk to other patients, so she's found a side room. Anita's parents find it hard to keep her engaged and stop her becoming distressed. She's not eating or sleeping well. She's in a strange environment and everything's different. The doctor won't discharge her yet, so they're faced with more time in hospital, and her parents don't feel it's safe to leave her.
Sorry, I'm scoffing a biscuit. Although quite complex, I think it's quite fair to say that we had the easiest case. A lot of it is quite straightforward. But I suppose, from dream to reality. One of the first questions, what could be done to make the hospital stay easier for Anita? Well, I think we have quite exceptional models where we look at Great Ormond Street as an example, when a child has to go into hospital for treatment, how accommodating they are to make it available for at least a parent to stay with the child, and how to make it less clinically dull and brighten the child's room up in terms of their toys, the familiar surroundings, to try and take the anxiety, pressure away. I can't see any reason why that shouldn't be done. We don't know the age of Anita, but we're kind of guessing that the parents are the strong point for Anita. So how Anita remains with her parents throughout this situation. The other question about what support could her parents ask for, I brought the question to my colleagues around the table. I find that language very difficult, because it shouldn't be about the parents asking for support. It should be about what support can be offered to the parents. The support should be on a platter. They should be able to choose from what support, or have support recommended. We're not looking at the whole situation about reinventing the wheel. It's identifying that it needs to be there. It should be there, rather than scooping and scraping, because if the parents weren't so maybe assertive, would support be offered at all? Would they be leaving hospital without any support and facing similar situations in the future?
Just to add on that, because Anita lives in the community with her mom, with her parents, so normally as we community nurses, we go out there and then we make sure that she's got like care passports, because when she goes in the hospital, there are things that she really need, like mom and dad is not there at that point of time, and they need to give her medication, so they need to know how to do it. So it makes the process easier for them as well.
Can I just add, sort of, because we were thinking about reasonable adjustments and establishing it. If there was a side room available once you started pulling things down, there was probably a side room available to start with. I've used hospital passports as well with clients when I've worked previously, and I mean, I'll use an example of yesterday. We were in a paediatric unit, but we were in a bay with curtains and all the rest of it. That was the only space available. When the curtains started getting pulled down and another young person's space started getting invaded, there was a side room. So that sort of preemptive stuff. The sad bit was the family said, "I'm glad you're with me because you're a professional and they might listen to you." And I think that's the attitude that we need to get away from.
Yes, I agree, and I think that as you say, we have support lots of families, and this whole side room miraculously becoming available when things have been trashed, or when things got really difficult. We need to be much more proactive in terms of planning and making that available. I think the other issue, yes, is around families, and the point you made about what families should ask for. I think, yes, you're absolutely right. It should be available, but our experience of the families that we support, and I accept that people don't phone us up and tell us, this is going really well, we just want to tell you about it. They phone us when things are difficult. But our overwhelming experience is not that families are told, here's a range of support options available to you, which would you like? They have to know what is possible and ask for it. And so, that's the situation that we need to get away from, so that they can, they can get to that point where they're going in and that it's planned, that everyone knows what's going to happen, everyone's on board with it. You don't have to make the case. I mean, my son displays a range of difficult behaviours. If he's supported well, he doesn't display those behaviours, but sometimes he has to almost prove that he can, that he will. And so, there have been times when I've said, Daniel finds waiting really difficult, we won't be able to wait in the waiting room. Oh no, I'm sorry, you're going to have to wait your turn with everyone else. And then we have to sit in the waiting room, and eventually, after about 5 minutes, we get moved somewhere else really quickly because we're upsetting everybody else. Dan's very difficult, he's running around, and we shouldn't have to do that. We shouldn't have to get to that point.
I was just going to say that sometimes the ward themselves don't know what's available or feign ignorance. I don't know whether it's intentional or unintentional. They haven't got the time to engage, and many times service users have landed in hospital. I'm a social worker in the CTPLD team, and it's just a constant battle. I've had to go to commissioning managers who are very approachable in our team anyway, and they've said to me, look, it's the one-to-one, if it's needed, should be part of reasonable adjustments. If you have trouble, we'll give you something in writing to remind them of that. But you'll never be offered that to start with. It's only on the third or fourth day after this constant conversations, and you say, look, you have an obligation, a duty, and then it'll, which they have to foot the bill for it, I think, because we put into a pot. And even if it means waking night, being with them, they have to provide it, but you never get that information. It's not forthcoming.
Yes. It's more staff attitude as well, because a few years ago, my daughter had cornea in the eye, so I had to take her to the hospital. Okay, it was my choice. I decided to take her home every night and bring her back, and it was Christmas period. It happened on the 24th of December. So, so I was offered, she said, yeah, you can look at the ward, and this is what we're going to look at it. And I thought, there's no way she's going to be happy. So I was taking her there every morning, 8:30, and I had to be seated in that waiting room until a doctor was available. The first day was 8.5 hours. The next day, about 6.5 hours. So no reasonable adjustments were made. Forget that. Every day I had a different doctor. The first day, she was okay. Second day is fine. She spoke to me and asked me things and so forth. And the nurses there were quite nice as well. So after waiting for 6.5 hours and trying to keep her engaged and entertained, it was quite hard. But never mind. She got seen to. She wasn't very cooperative. But the doctor would say, is she be okay in this cubicle, or shall we go to a private room? That's fine. That was a lovely, compromise. I said, yeah, private room. So he managed to get the drops. He managed to check. And so obviously every day the medication got changed. On the fourth day, I ended up getting a doctor who didn't even talk to me, didn't do anything, just said to my daughter, sit down. He told her to sit down. She pushed him. She pulled the curtains down. And he goes, can you call security? And thank God I'd been there for 3-4 days, and the nurse had seen the way I'd been dealing with her. She goes, no, I think her mother's dealing with her nicely. I said, well, I'm sorry, I'm not going to have a scene here. I'm going to go to that private room. So I took the initiative and just walked her into the private room, where she calmed down. And I said, I'm sorry, I don't want a scene today. So the following day, a couple of days later, another doctor. He's lovely. He was so amazing. Honestly, he spoke to me, he spoke to my daughter, he took his time, and he really examined her. And he actually managed to get proper examination. And then he was one that discharged us to outpatients. And I said, look, in the outpatients, it's been very quiet over the Christmas period. Outpatients, you will not be able to cope with it. He said, it's okay, I'll give you an appointment. When you come to the receptionist, can you tell them that you are here and that they should inform me? Very nice. He made the reasonable adjustment. We got there. We told the receptionist, can you let Ed, that was his name, know that Mrs. Sandu and Mindy are here? I said, no, sorry, you have to wait to your turn. So a few minutes later, Mindy started pacing up and down. I thought, no, she's going to hold. So I went again, and I spoke to the other receptionist. She said, no, sorry. But luckily, because I'd been going there for about 3, 4, 7 days, I'd seen one of the doctors. And I said, excuse me, by the way, is Ed in his clinic? She goes, yes. Can you do me a favor? Can you just tell him that we're here? She said, okay. So she turned back, and she went and told him. And by the time Mindy was, sorry, my daughter, she was getting quite pushy and quite challenging. So I always find my safe haven is the disabled toilets.
So I was slowly escorting her to the disabled toilets. When he came, he said, "Oh, Mrs. Sandu, just give me 2 minutes." He literally finished with his patient and came and saw me straight away and said, "Oh, I'll go and find a private room." That's what I mean with staff attitude. It was his attitude that Mindy was seen properly. He did a thorough examination, whereas all the other doctors couldn't do anything with her. Sorry, I took a bit of time.
Thank you. Thanks. I'm just sending around a sheet that I hope that you'll all fill in, because one of the issues that we found at the CBF is that although there's quite a lot of information about the small adjustments for people, like sort of extended appointment times and so on, there's less information available about the big adjustments, and it's addressing the point that you made on your table, which is people shouldn't have to ask for it for additional support. So it's about, have you not got enough? It's about making sure that we're thinking at the CBF about producing an information sheet that would be easy for people to say, well, here's some things that you can do, and it's some top tips, and they can just hand it over, or they can wave it at people. So if you're able to fill it in, please do. You don't have to leave your contact details if you don't want to. But if you've got some good practice to share, for example, it's always helpful to say to people, look, it can be done. It's been done in this area, or other people have done it. Have you run out here? Did you ask for some? Okay, and I think that's it. It's lunchtime. So thank you for all your contribution. Please do look at our website. There's loads of information there for families. You can direct families to it. As I said, all our information is free for families. There is information there for professionals as well. You know, yeah, just share the information that you've got. So thank you for coming, and thank you for your contribution today. Thank you.